Welcome to This Explainer. Okay, today we are diving headfirst into a literal medical mystery hidden right inside an everyday symptom. We're looking at a brand new scoping review about a condition that totally masquerades as a standard, run-of-the-mill muscle ache, but is actually a vascular event, and it needs immediate attention.
I mean, we all get stiff necks, right? You sleep funny, you spend way too many hours hunched over a laptop, maybe you push it a bit too hard at the gym. But let me ask you this, how do you know when that severe neck pain is actually a precursor to an ischemic stroke? It's a terrifying thought for sure, but it is absolutely crucial to consider, especially for clinicians on the front lines who are evaluating everyday aches and pains. To figure that out, we first need to understand the hidden danger we're actually looking for.
Section 1. What exactly is a VAD?
So VAD stands for vertebral artery dissection. Basically, this happens when there's a tear in the inner layers of the artery's wall. Specifically, we're talking about the extracranial portion, which just means the segment of the arteries located right outside the skull. Now, this tiny tear sets off a whole cascade of events. It can create a pseudoaneurysm that totally blocks blood flow, or even worse, it can trigger a blood clot that travels straight to the brain and causes an ischemic stroke. The really tricky part here, during that early, non-ischemic phase, a VAD literally disguises itself as a typical musculoskeletal neck issue. That makes it incredibly difficult to catch before the stroke phase actually begins.
And wow, this next stat brilliantly illustrates the high stakes. The average age of a patient experiencing one of these extracranial VADs, just 36.8 years old. Think about that. And on top of that, almost 64% of these patients are women. This totally shatters that illusion we have that severe arterial issues and stroke risks only affect the elderly or people with a massive history of cardiovascular disease. This is striking young, otherwise healthy individuals.
Moving on to Section 2, the red flag myth.
Now, what's really interesting here is how the new data completely challenges everything clinicians are taught to expect. Historically, medical professionals rely on standard guidelines to catch these serious conditions. They are trained to look for a specific set of classic neurological warning signs, which they usually call red flags. Tools like the iFount cervical framework were specifically designed to help clinicians spot these vascular pathologies early on by giving them a straightforward checklist of symptoms to watch out for whenever a patient walks in complaining of a sore neck.
But a comprehensive new scoping review decided to put those very guidelines under a magnifying glass. The researchers analyzed 46 different studies, covering 58 patients, and they looked strictly at cases where the patient's primary main complaint was neck pain. They basically wanted to know, do these classic textbook red flags actually show up in real-world patients whose main symptom is simply a painfully stiff neck?
Well, here is the plot twist. Those classic textbook red flags, they were almost never actually reported in these patients. Symptoms like ataxia, a lack of muscle control, facial palsy, ptosis, which is a drooping on the eyelid, and dysphagia, or difficulty swallowing. These are traditionally seen as the absolute hallmarks of posterior circulation involvement. But in this review of patients with neck pain, they were virtually absent, nowhere to be found. This means the standard checklist might be completely failing us when it comes to identifying these VADs in their early stages.
Which brings us to Section 3, what the evidence shows.
Let's actually look at the data to see what a VAD looks like in the real world, instead of just what the textbooks tell us. Instead of those super rare neurological red flags, the true early warning sign usually centers on the pain itself. The data reveals that VAD neck pain is typically unilateral, meaning it's located on just one side of the neck. It's almost always described by patients as incredibly severe or intense, but most importantly, it simply will not go away with standard painkillers like ibuprofen or muscle relaxants. It's also often accompanied by pain that radiates up to the head, creating a really unusual headache or spreading down into the upper limb or shoulder.
Now, when other symptoms actually do pop up alongside the neck pain, this data shows us what clinicians actually need to be looking for. It's usually upper limb weakness, which affects about 38.5% of these cases. Dizziness or vertigo comes in a very close second at 35.9%. And we also see systemic issues like nausea and vomiting in roughly 24% of cases. So, as you can see, this paints a totally different clinical picture than the traditional guidelines suggest.
Section 4, rethinking clinical checklists.
So, the absolutely crucial point here is, if the old checklist doesn't work, how do we actually protect ourselves and our patients? Well, we have to start rethinking clinical checklists entirely.
Since the symptoms can be so vague, we have to look closely at real-world risk factors. The most commonly documented risk factors in the literature were current smoking and pre-existing hypertension. We also saw that roughly a third of the cases were tied to a recent cervical trauma or even just sudden neck movements. But guys, here is the most alarming statistic by far. In 50% of all the cases reviewed, literally half of them, there was absolutely no identifiable cause or trigger for the dissection. No warning, it just happened.
As the researchers concluded in their review, clinicians really must look past a simple checklist. The traditional approach might honestly cause more confusion than clarity if those classic red flags simply aren't there. Instead, they highly recommend relying on holistic clinical reasoning. You really have to consider the atypical nature of the pain, any pre-existing risk factors, and even the most minor neurological signs, all while maintaining an incredibly high level of vigilance. This is especially true because these early warning signs can be so transient and subtle.
Which leaves us with a pretty provocative thought to end on today. The absence of frank, obvious warning features shouldn't automatically reassure us. Whether you are a patient advocating for your own health and dealing with severe, unresponsive neck pain, or you're a clinician trying to diagnose a stiff neck in a young, otherwise completely healthy individual, you have to ask yourself, are you really looking at the whole picture, or are you just ticking boxes?